Welcome to Focus on Your Health, your radio home for news and stories from Kingman Regional Medical Center, here on the KJAZ Radio Network. I'm TG LaFredo, and this week I'm coming to you from Scottsdale, from the Opening the Doors Conference. My guest is Will Humble, Director of the Arizona Department of Health Services. Hi, Mr. Humble. Welcome.
Good morning. Thanks.
Glad you're here. Let's start out with what you're doing here. What is Opening the Doors?
This is a conference that we put together with United Healthcare here in Arizona to try to improve the network of providers, clinicians actually, that have the tools that they need inside their clinical practice to help people with special needs. One of the shortcomings that we have as a state, not just in rural Arizona, but throughout the state, is a lack of providers that know what to do when a person with special needs comes asking for services with their medical practice. It could be a behavioral health need, might be a kid with a special mobility problem, could be somebody with some developmental disabilities, and clinicians sometimes don't have the tools that they need to be an effective provider for that population. So we put together a series of forums to try to improve the skill set that we have amongst clinicians in Arizona and to get these early adapters, because let's face it, the folks that are at this conference are people that are receptive to providing services for folks with special needs. And so what we want these folks to do when they leave is to get with their network of colleagues and try to recruit more folks into the network of people that are enthusiastic about providing services to people with special needs in Arizona.
So obviously there's a need, because that's why this is going on. If you had to make an assessment of how providers are doing to give care to people with special needs right now in Arizona, what would you grade them?
Well, I think by and large in the urban areas in Phoenix and Tucson, a family that's diligent, that wants to really find a provider that can accommodate their kid's special needs or a family member with behavioral health needs, that network is really in place in the urban core. But like many things that we see in both primary care, but also, in behavioral health services, is that the network gets thinner as you go into the rural parts of the state. And so the focus here is to try to build that infrastructure, especially for our rural providers, so that we can recruit more folks into the network that actually are able to provide those kinds of services, but also for those people that are providing services already, to give them better tools so that they can be more effective when it comes to working with people with special needs at their clinical practice.
Right. I know a fair amount of our listenership they're out there in the hinterlands. It's a ways to medical care. For some of them, it's a ways to water. They truck in their water, which is a whole different way of life. Thinking about some of the towns 50, 60, 70 miles outside of Kingman, for them, Kingman is the big city.
Right.
If you live out there and you have a child with special needs, what sorts of resources are available? How do you go about trying to adapt and make life better for that kid?
Right. Well, I mean, you hit the nail on the head when it comes to some of the bigger challenges we have as a state. And I mean, let's face it, if you're in a rural or frontier part of the state, something that will never change for you probably is that you will always have more challenges getting to specialized healthcare.
Sure.
What we're trying to accomplish here is to, better build out that network in the smaller places like Kingman and Payson and Prescott and some of the smaller parts of the state, and make that care more accessible, right. Recognizing that it's never going to be like Indian School and 7th Street,
sure, of course,
down in the valley.
Right.
It will never be like that. But we want to improve the network to make it easier so that folks, when they do make that drive to the office, that visit is effective and they get what they need.
And worth the gas money and the time.
Right. The other initiatives that we're working on include telemed, which has a lot of potential because of the new technologies that are available, both on psychiatric telemedicine, but also primary care telemedicine. I mean, if you roll back the clock just 10 or 15 years, the technology existed for telemedicine, but it was extremely expensive and there were so many barriers to entry, it was unaffordable. We've got to a place now where technology makes that a lot easier to do. And so, telemedicine these days can sometimes be as simple as something like Skype.
Right.
So if somebody has internet connection, you can have a clinical visit, hundreds of miles away with an iPad.
Yeah.
So technology has really opened up a whole range of possibilities on telemedicine that we haven't had before. Now, more complicated telemedicine procedures will still need that more complicated and sophisticated telemed technology. But there are some things in the primary care world where something like a Skype visit can really have a positive outcome and avoid a long drive. So we're exploring those things and trying to build that out and use technology as a tool for rural Arizona.
When I think about your job description, you're essentially in charge of the health of this whole state, which is, well, it's got to be daunting to say the least. I can't imagine what it takes for you to keep on top of all of this stuff and know you're constantly taking the temperature of the state to figure out what's going on.
I really look at my job as a systems analyst, not in the IT world, but in healthcare and population health. So our job is to set up systems of care and a public health surveillance system and a set of public health interventions that help the system as a whole end up developing and a network that improves public health outcomes. Right. So at the public health level, at the health department level, our job is to really set up systems of care that are effective at producing good outcomes. So a clinician, for example, at this conference, that person's job is to work one-on-one with individuals. Our job at the wholesale level or at the public health wholesale level is to set up systems to make good outcomes. So for example, one of our priorities as an agency is to improve access to care. That means getting a wider array of providers that can help people, especially with special needs, but really anybody, and then make them more effective when they do have their patient time. So we set up conferences like this with the goal of building out that network. Right. We talked at the beginning of the conference about our initiatives around behavioral health. Again, a systems approach. We look at the fact that people with a serious mental illness live 25 years less. In other words, they die 25 years younger than a typical peer. Yeah. That's unacceptable. And they're not dying from a psychiatric illness. By and large, they die from untreated diabetes or hypertension, underlying things like diabetes that result from obesity, from poor nutrition and lack of physical activity, those kinds of things. So we've reworked the way we deliver behavioral health services in Arizona. Right. So in Maricopa County, that was our test case where we reworked the contract that we have to deliver behavioral health services in Maricopa County. We've got a new contractor down there called Mercy Maricopa Integrated Care. And that contractor is responsible for managing the whole person. In other words, if somebody has a serious mental illness, that it's called a Regional Behavioral Health Authority, essentially a health HMO, really, is responsible for making sure that that person's health in general is taken care of, not just their psychiatric illness, but the rest of them too.
Okay. Any other medical problems.
Right. And for the last 35 years in Arizona, it's been a bifurcated system. And so a person with a serious mental illness would get their psychiatric services from their psychiatrist and from a health plan that specializes in psychiatry and behavioral health issues. And their other issues like diabetes would be taken care of by a whole different set of clinicians and a completely different HMO. Well, those data books, that data on that person were never shared. And so you could have a person with a serious mental illness that had a chronic debilitating medical condition result like diabetes or something. Right. And the psychiatrist doesn't know what's happening in terms of the primary care that person's receiving. And the person ends up dying because of untreated diabetes. Well, it was because of bifurcated care. So what we've done is to merge for a person with serious mental illness, those responsibilities within one entity, and then put that entity at risk. It's called a risk pool for the entire cohort. And through better care coordination, right, by using data analysis to look at the entire person, we'll be able to do two big things. My main motivation is to improve public health outcomes for those folks so that their chronic illness is treated in coordination with their psychiatric care, right? That's my interest. But another big payoff is that actually reduces costs.
Sure.
Because one of the big cost drivers for people with a serious mental illness when it comes to their inpatient hospitalizations for a chronic illness is that they keep ending up in emergency departments and then in inpatient in a hospital because of something like lung disease or heart disease or something. Those become really expensive hospital visits that were unnecessary, maybe unnecessary, if that person had better primary care and had that diabetes treated earlier or the hypertension was managed more effectively.
Right.
So that's what we're really after here, is to better coordinate the care so that we prevent bad outcomes before they are bad outcomes. And the side benefit is that it's actually less expensive to do things the right way.
Right. And you've been testing this in Maricopa County.
Right. So our test case is in Maricopa County. That contract started in April.
Right.
So we're looking at that data. We will expect to see decreases in hospitalizations throughout the course of that contract. And then we're also in the process of rolling that out also to northern and southern Arizona. So the current contractor in northern Arizona is called the Northern Arizona Behavioral Health Authority. People might know that as the acronym NARBA.
Okay.
They'll have the contract at least until October of 2015. But what we've done now is release what's called in state government an RFP, or request for proposals, for people to bid on that Northern Arizona contract, very much like in Maricopa County, where the winner of that contract will end up being responsible for providing behavioral health services and primary care services, both for people with a serious mental illness. They'll also be responsible for providing it for just general mental health and substance abuse as well, but not the primary care in that what we call GIMSA population. Anyway, that contract is out for bid right now. The due date is in October.
Okay.
And between October and December, we're going to evaluate those bids and award the new contract at the end of the year in 2014, and then make that transition and pivot to that new system of care in 2015. So the new contractor will be available and out there in northern Arizona with that new model in October of 2015. When I say new contractor, those of you in NARBA land, don't worry, that doesn't mean you're not going to qualify for the bid. I'm just saying the model of care that we'll be using at the end of 2015 is very different from the model of care and our expectations with the current behavioral health system in northern Arizona.
It's break time on Focus on Your Health. We'll be back in just a moment with the second half of my conversation with Will Humble. This is the KJazz Radio Network. And welcome back to Focus on Your Health here on the KJazz Radio Network. This week I'm speaking with Will Humble, Director of the Arizona Department of Health Services. Mr. Humble, before the break, we were talking about the contract for behavioral health. When you say that you're accepting bids, are those from groups that are already in place, or are they sometimes from outside groups that say, we can come in and we can fix what's wrong there?
Yeah, so it's really both.
Okay.
So in Maricopa County's case, it's $1 billion contract in Maricopa County per year, so it's a big deal. We had 6 or 7 bidders for that Maricopa County contract. The winner ended up being a new entity called Mercy Maricopa Integrated Care, MMIC. So it's really a new entity that was sponsored by Mercy Care, which is a Medicaid primary care and acute care health plan.
When you're evaluating those bids, obviously you have to evaluate cost and you have to evaluate the bidder's ability to provide the care. Are there some other X factors that...
Some of the biggest X factors are really, we're looking for bidders that show innovative evidence-based practices. So as you said, there's a capitated rate, so cost is always a factor, but we're always looking for in our bids are folks that can demonstrate that they're using evidence-based proven practices, that they're heavy into community involvement, that they're really working with the community in developing their system of care, and that they've got systems and monitoring in place so that they have quality improvement throughout the process. So I'm not allowed to say any more than that
Sure.
because it's a procurement, but we always look for innovation as one of the key elements in everything that we do at the department.
When we first got together this morning, you said, we're talking about Northern Arizona. I have some Northern Arizona news for you.
Shoot.
Let's talk about the immunization rate in Northern Arizona.
Yeah, well, one of the struggles that we've had as a state is that the immunization or vaccination rates in the northern part of the state are not as good as we'd like them to be.
Okay.
We've done some analysis with the University of Arizona looking at vaccination rates among kids over the last several years, and consistently we find that vaccination rates among kids in Yuma, Tucson, the southern parts of the state are awesome.
Okay.
We've got no complaints. I mean, vaccination rates are among the best in the whole country in southern Arizona.
That's incredible.
Which is really good. You move into the middle part of the state in Maricopa County, you start to see some slippage in vaccination rates, especially amongst kids that are homeschooled, kids that are enrolled in charter schools and private schools. The parents that select those alternative education venues also tend to seem to choose not to vaccinate their kids at the rate that we'd like to see. And then as you move to the northern part of the state, we see our worst vaccination rates. So the Flagstaff area, northern Arizona in general, have pretty poor vaccination rates when it comes to the number of kids that are fully vaccinated for all of the immunizations that keep not just them healthy, but the community healthy. And the reason that's important is that vaccines work because of something called herd immunity. In other words, the vaccine that you give your kids is going to protect your kids, but the important thing is that it protects other kids. Right. So that if a measles virus from the Grand Canyon from a European visitor or something comes into your community, that even if there's an under-vaccinated kid in your classroom, if all the other kids are vaccinated, it doesn't matter. The virus has nowhere to go, right? So that's what herd immunity is, and that's why it's so important to keep vaccination rates high so that really infectious diseases like measles don't get a toehold in a community, because once that happens, it's really hard to eradicate. I mean, Europe has had horrible struggles, especially Switzerland, but all throughout Europe with measles. California has a measles epidemic that's been going on for years now. Really expensive, bad outcomes, and avoidable if you can just have acceptable immunization rates. And so one of the challenges we face in our state is that the vaccine rates in northern Arizona aren't what we'd like to see. Interestingly, on the Navajo and Hopi reservations in Indian country, the vaccination rates are great. Okay. So I can't say all of northern Arizona is the problem, but it's in, the areas of Coconino, Mojave counties that we see the biggest issues. And the longest running and biggest struggle that we've had is actually on the Arizona Strip, where we've got a continuing whooping cough outbreak in those communities that just is rampant. And it's a real struggle to get those vaccination rates up. Because it requires a community commitment. It's one thing for the state health director to talk about immunization rates and vaccination rates, but really what's most effective is a conversation between a mom and a pediatrician in the pediatrician's office, where they can actually describe why it's important to vaccinate their kids, and they can have that in-depth conversation to alleviate the fears from the parents about what they perceive to be the risks of vaccination. And, what we call vaccine hesitancy is an increasing problem, especially in the northern parts of the state. The biggest challenges in the whole state are in the Sedona area, where we've got a school district that has very low immunization rates. And they're quite honestly at really high risk of at some point having a pretty bad measles outbreak in some of those schools in Sedona. And I don't want to make it sound like I'm bashing Europeans, but they come to the Grand Canyon and a lot of them get sick with measles because they're unvaccinated. And there's people from all over the world up there, and that can spill into places like Williams and Flag and Sedona, because the people that go to the Grand Canyon also, they stay in Williams. Flag's an awesome place. They go there. They go to Sedona. it doesn't take much for a measles virus to get a toehold in a community like Sedona that's got low vaccination rates amongst the kids.
I'm trying to get the subtext as to why. Okay, so I can hear that in certain places, okay, we're doing homeschool. I think there's kind of like an alternative theory going on with some of those parents. And then in Colorado City, I know there's probably some religious exemption that some of those people are claiming why they don't want the vaccines. I'm trying to figure out why, in general, okay, Sedona, there's some kind of enlightened hippie, a flower child ideal that, oh no, we don't use vaccines. They're against nature or something like that.
Well, what we see is that it's definitely related to income. Most things in public health, the poorer you are, the higher risk you are for stuff, right?
Yeah, sure.
Vaccines are the opposite. The higher income you are, the more likely you are to choose not to vaccinate your kids. But one of the ways I've been trying to frame this for communities like Sedona is to, instead of talking about why the vaccine protects your child, reframe it as a social contract that you have with your community,
okay.
Right? Because folks that, we were talking about the enlightened type, right? Well, they think of themselves as socially responsible.
Yeah, part
right?
of a
They
web,
might even
right?
be concerned about their carbon footprint or that kind of stuff, right? But
Sure.
when it comes to vaccinating their kid, they only see it as a personal risk,
Right.
rather than a community responsibility.
Right.
So what I've been trying to do, and I wrote a little piece in the Red Rock, the newspaper up there and stuff, to talk about vaccination as a community responsibility and a social contract with your fellow human beings, rather than viewing it as something that's a personal issue. It's really not personal. Vaccines work, like we said earlier, because of herd immunity. Communities that are vaccinated are healthier. So it's really about community health, not individual health.
To my knowledge, this whole fervor, this whole mania against vaccines began from one specious study.
It wasn't even a study. There was a case series published in a journal called Lancet from a quote-unquote research. It was a physician, Wakefield his name was. It was just an observation that he was throwing out there.
An article,
at the back,
essentially.
Yeah. In the back of the Lancet. And it didn't go through peer review or anything.
Right.
But it wasn't the article itself that started this. It's the fact that clinician used that article to become a celebrity,
Right.
and give speeches all over the U.S. and Europe, alleging that there's this link between vaccines and autism.
I bet he made some good money doing that.
I
as
think
well.
so, but he's ruined his reputation. I don't know if he cares about that or not.
Yeah.
But it created this decades-long firestorm that we're still struggling with in public health. And there have been so many studies that have been done in the U.S., in Japan, and in Europe that look at that alleged idea from that clinician all those years ago in the UK. And every single study points in the same direction, that there's absolutely no association between vaccination and autism. Yeah. But yet the stories are still being told in playgroups all across this country. And it's really frustrating.
Well, it resonates because it touches people where they're vulnerable. If you have a child with autism, I don't mean this as an indictment, but I suppose it makes it easier if you can blame somebody. If you can say, this would not have happened but for this evil pharmaceutical cartel that made this thing happen.
Right. And I think that's partially true. And I think one of the struggles we have is that there is definitely an epidemic of autism in this country.
Sure.
And we don't know why.
We've
right?
seen, yeah.
So if public health could come out and say, we've figured out why we've got so many more diagnoses of autism. Right. If the medical community had an answer, that would be a lot better, because it would give us a clue for what kind of interventions we might need to do as a society and as a culture. Right. But for families, it would offer an explanation.
Right.
But it's a very real problem. I mean, there's absolutely far more people diagnosed with autism today than in decades past, and we don't know why.
That's Will Humble, Director of the Arizona Department of Health Services. Mr. Humble, thanks so much for your time.
Hey, thanks for the invitation.
And that's the show. I'm T.G. LaFredo. Thank you for listening. And please join me again next Saturday at 11:30 a.m. for another edition of Focus on Your Health, right here on the KJazz Radio Network.